and thank you for joining us at PA-SOS. In this segment, we're going to talk about asthma. Asthma is defined as a chronic, obstructive, reversible airway disease, primarily of the small airways. Now, I know that was a lot of different words, but essentially, when we're talking about an obstructive airway disease, we're talking about one in which there is severe bronchoconstriction to the point where there's a difficulty in letting air out of the lungs. In the case of asthma, we find that this obstruction or this bronchoconstriction is indeed reversible, something that we don't see with diseases like COPD. Another important thing to understand about asthma is that it is a chronic airway disease, but usually patients will have acute asthma exacerbations, usually triggered by some sort of intrinsic or extrinsic factor, which we'll talk about shortly. In general, asthma is going to be seen most commonly in children or adolescents younger than 18 years old. And one of the biggest risk factors that we see for asthma is something called atopy. Atopy is this genetic predisposition towards producing IgE antibodies after exposure to certain allergens. There are a lot of different diseases that are associated with atopy, but the classic atopic conditions that are good to know are atopic dermatitis or eczema, nasal polyps, allergic rhinitis, and of course, asthma. One way that the concept of atopy is very important for both students as well as for clinicians is that when we're presented with a patient that has atopic dermatitis or nasal polyps, we're much more inclined to think that they may have or will develop asthma. Now, in general, we find that asthma can be classified also as either extrinsic asthma or intrinsic asthma. And most commonly, you'll see patients have extrinsic or atopic asthma. In this type of asthma, we're seeing that there's some sort of extrinsic or external entity, or what we call an allergen, that enters into the airways and causes the body to mount an exaggerated hypersensitivity response. Again, here we're seeing that IgE-mediated immune response, which essentially causes the release of histamine and other cytokines, which ultimately lead to airway edema, increased mucus secretion, and most importantly, bronchoconstriction. All these things in combination essentially decrease the caliber of that bronchial lumen and thus make it harder for air to leave the lungs. As this inflammation continues, we find that other inflammatory cells like neutrophils and T cells start to join in and create even further inflammation, kind of like insult to injury. Meanwhile, in intrinsic asthma, we typically see patients have an hypersensitivity reaction to an intrinsic factor, or what I like to describe as a non-organic factor. Things like exercise, cold air, NSAIDs such as ibuprofen and aspirin, or even respiratory diseases like with respiratory viruses. Remember that a virus is technically not organic. There's actually a specific type of asthma called aspirin-exacerbated respiratory disease, where we find a special subsect of patients with asthma who have also allergic rhinitis, nasal polyps, and a propensity towards asthma exacerbations when taking aspirin or other NSAIDs. It is this particular concept that makes us very weary about administering aspirin or ibuprofen in patients with asthma, because we may cause them an asthma exacerbation. We find that a lot of the problems that we see with asthma are essentially going to revolve around a concept called air trapping. Remember that we have bronchoconstriction occurring within these airways in patients with asthma. Well, what we see with this bronchoconstriction is that even though patients are able to generally bring in air into the alveoli, they have a very difficult time expelling that air out while they're exhaling. Now, this is a problem because eventually we get a buildup of stale air within these alveoli with less and less space for new air to come into the lungs. This air trapping ultimately leads to hyperinflation of the lungs, such that there is a decrease in the amount of space that is allowed for vital capacity, which is the amount of air within the lung that is accessible. To better illustrate this, take a look at the diagram over here. To better illustrate this concept, take a look at the diagram that we have at the bottom here. Normally, we expect that every time you take a deep breath in, you should be able to expel all that air out as well. However, in someone with an asthma exacerbation, they are able to bring in air, but they're not able to expel all of that air they brought in. But they'll continue to take in more air and more air until they run out of space to take up any more air. In other words, they have a decrease in their vital lung capacity, or the amount of air that is accessible within their lung. At the same time, we see that they have an increase in their residual volume. Residual volume is the unaccessible lung space and normally is kept to a very low amount. However, in the case of asthma and air trapping, we find that residual volume greatly increases, in turn decreasing the vital lung capacity. One of the hallmark clinical manifestations of asthma is wheezing, which is this whistle-like sound that can be heard upon auscultation. The noise is essentially being made because every time a patient is trying to breathe air out, the air is banging against all these narrowed walls of the bronchi, making noise as they exit. Classically, patients will have worsening of their wheezing and other symptoms at night. And we find that this is because, in general, we have a circadian variation to our bronchi, where naturally at nighttime, they're a little bit more constricted. So a patient with asthma, this can become quite severe. The presence of airway trapping ultimately leads patients to feel short of breath, they'll have chest tightness, and they'll often have a cough. And when you auscultate these patients, you'll classically hear wheezing, but with a prolonged expiratory phase, meaning that it takes them longer to expel air out of their lungs, which is exactly what we expect in asthma. If left untreated for a long period of time, an asthma exacerbation can ultimately become something called status asthmaticus, or acute severe asthma. One way that you know that you're dealing with someone with acute severe asthma is that classically these patients will have very low pulse oxes, such as a pulse ox of less than 90%. These patients may also seem to be speaking in incomplete sentences or breathing very quickly or using their accessory muscles to try and help them breathe out their air. Ultimately, however, these patients may tire out and stop taking deep breaths in or out and develop silent chest, which is where you listen to the lungs and you do not hear movement of air in and out of the lungs. The best way to diagnose asthma is by performing a pulmonary function test, also known as spirometry. Now, in order to better understand how a pulmonary function test can diagnose asthma, it's important to first understand some of the concepts like FEV and FVC. Forced vital capacity, or FVC, is a good measurement of how much air the lungs can hold that are accessible to the patient. FEV, or forced expiratory volume, is how much air a patient can blow out when they try to blow as hard and as fast as they can. If you take a look at the diagram on the right here, you see that most patients are able to expel about 80% of the air that is within their lungs within the first second. However, in a patient with obstructive airway disease, such as someone who has asthma, we find that that air takes a lot longer to be expelled out of the lungs, again, because of that bronchoconstriction. Therefore, a patient with an obstructive airway disease usually expels much less than 70% of their lung space within that first second. And classically, we see that patients with obstructive lung disease will have an FEV1 to FVC ratio of less than 70%. One of the key features in asthma is that this obstructive pattern can be reversed by giving the patient a bronchodilator, something that we do not see in many of the other obstructive diseases like COPD. In uncommon instances, we may have patients who get false negative tests on a pulmonary function test. In patients that we still believe may indeed have asthma, even though they're not showing signs of it on the pulmonary function test, we can perform a bronchial provocation test. In the bronchial provocation test, we provide patients with a medication like methacholine, which causes the patient's bronchi to bronchoconstrict. In a patient with asthma, we find that they'd have an obstructive airway pattern when given methacholine. In other words, a negative bronchial provocation test strongly rules out the possibility of asthma. The management of asthma exacerbation will essentially require bronchodilators. But in order to better understand some of the medications that we may use, I want to first talk about the physiology of the bronchi. We find that the airways are covered in beta adrenergic receptors, as well as cholinergic receptors. Activation of beta-adrenergic receptors will cause bronchodilation. Meanwhile, activation of cholinergic receptors will cause bronchoconstriction. Therefore, we can cause a patient to have bronchodilation by either giving them a medication that is a beta agonist or a medication that blocks these cholinergic receptors. The mainstay of therapy for asthma exacerbation is thus a short-acting beta agonist like albuterol. Albuterol will bind to these beta-2 receptors and cause the bronchodilation that is necessary to help this patient breathe better. It is an extremely fast-acting and effective medication, and thus every patient with an asthma exacerbation should be treated with a short-acting beta agonist. Clinically, we'll often also see that we combine a short-acting beta agonist with something like a short-acting anticholinergic, like ipratropium. By blocking those cholinergic receptors, we can again cause that bronchodilation. Usually, however, something like albuterol is not going to be enough to treat the patient, and we'll have to add on other medications like systemic corticosteroids. Classically, we use medications like prednisone orally or methylprednisolone via IV. Remember that asthma has a very strong inflammatory process, especially in the late phase via those neutrophils and T cells. Well, that means that if we're going to help decrease some of that inflammation, we're going to require a medication that is an anti-inflammatory, like a corticosteroid. Keep in mind that these systemic corticosteroids do come with their side effects, most commonly hyperglycemia. With prolonged use of systemic corticosteroids, we can ultimately develop something called Cushing's syndrome, which we talk much more about in a separate section. Some of these other side effects that you see with systemic corticosteroids, like immunosuppression, osteoporosis, impaired wound healing, all have to do with what the physiology of glucocorticoids are, which we talk about again in another segment. Keep in mind that these systemic corticosteroids are not for daily use, and we only use these things if a patient is having an acute asthma exacerbation. There are some other medications that you can also provide, like magnesium sulfate, which is very well known for reducing the rate of hospitalization in asthma exacerbations. Or something like epinephrine, which is a very powerful beta agonist, but is usually reserved for status asthmaticus due to the negative side effects that can come with it as well. While things like short-acting beta agonists, short-acting anticholinergics, or systemic corticosteroids are going to be used for acute asthma exacerbations only, we can also provide patients with chronic asthma medications in order to minimize the number of times they have symptoms. Inhaled corticosteroids like beclomethasone or budesonide are going to be the best medication to add on for chronic asthma. Just like those systemic corticosteroids, inhaled corticosteroids will affect that inflammatory process of asthma and thus help prevent asthma exacerbations. If an inhaled corticosteroid is not good enough alone, we can also add on a long-acting beta agonist like salmeterol, which, unlike albuterol, which work fast and hard, salmeterol tends to work for a longer period of time, but is not as strong. Again, these medications are to be used for chronic asthma management and should not be an answer that you provide for the acute exacerbation of asthma. There are some other chronic medications that we can use that can be useful in certain types of asthma patients. For example, leukotriene modifiers are very useful in that subset of patients that get asthma exacerbations due to exercise or aspirin intake. Leukotriene modifiers like montelukast or xyluton will help decrease leukotriene activity or pro-inflammatory activity, something that we often see in our patients with asthma when they take aspirin. Cromolyn sodium is another great medication that can be used as prophylaxis for patients who get exercise-induced asthma. Cromolyn sodium essentially stabilizes the membrane of those mast cells that normally play a role in inciting an asthma exacerbation. Lastly, there are things like anti-IgE monoclonal antibodies like omalizumab, which will essentially target the pathophysiology of asthma. Remember that it's the IgE antibodies that started this whole mess, and so patients may often get shots of omalizumab in order to help decrease the amount of circulating IgE. While this may sound like it is the best of all of the treatments, it is important to understand that this is a very expensive product and thus is typically reserved for more moderate to severe asthma. This concludes our segment on asthma. Thank you.